Yeah. So these days, they after the talk, I send to media office and they, edit for any privacy or something, and they just usually just upload it. Now it's pretty fast. They upload it to Johns Hopkins YouTube channel or something, so should be
Cool.
able to see pretty quickly. So
That's cool. Yeah.
because a couple of people couldn't make it today, they asked me, "Hey, Greg."
Happy New Year, everyone.
Happy New Year to you.
Well,
Happy
thank you.
New
And may
Year.
it be a year full of blessings for all of us.
Mhm.
Things are a little tough in Minneapolis right now, and
Oh,
so
Yeah.
it's
Yeah.
we
a little
we
painful.
and everything there. Well, I think maybe we can probably wait just a couple more minutes, but before I forget, because I know usually we have a lot of discussion after the talk, we're gonna have some big announcement changes in this meeting, and I will probably send some more formal announcement in email. So just pay attention to that. A lot of good changes, actually. So, and this is actually the last a link for the recurring meeting, so I'm gonna have to renew it. And before I renew it, I'll make some more big change announcements soon. All right. I think probably it's better if you can, get started. Uh,
That was great.
early. As you know, Andrew and is a female doctor like myself. So
Find each other. Yeah. So
we met at the the female conference group. You're part of RMSTP, right?
Mhm.
So RMSTP is also a subgroup of PMNR research people, and we learned that actually he's a spinal cord injury specialist, but he's been working on particularly autonomic dysfunction in spinal cord injury population. And interestingly, when I first started POTS clinic, actually, I told you, Andrew, I've been actually getting quite a bit of referral from spinal cord injury clinic, and all these patients have POTS. I mean, I don't know if we can label as a POTS or not, but a lot of people suffer from spinal cord injury. And for those who are not really familiar with spinal cord injury, actually a lot of people with the spinal cord injury, they do well functionally. And but when they have autonomic dysfunction, they really suffer. And I think that's very underappreciated by a lot of medical doctors, especially for those who don't understand spinal cord injury really well, right? So that's why we really hit it off. And I'm really, really looking forward to this talk. So he's at Craig Hospital in Denver, Colorado, which is one of the biggest top-notch rehab hospital in the country. And he's one of the very few clinician scientists in pulmonary field. So Andrew, you can take it from there. And again, thank you so much for your time and talk.
thank you, Tay. That was very generous of you. And I do remember when we first met in AAP and started chatting, and I was very interested in your work. And so nice to see everyone again. I met a few of you at the last AAS conference, and I joined a few weeks ago regarding this group. And what I've really appreciated about this group and Tay and AAS meeting actually was it just I think we're working in very similar and parallel discussions, but there's a slight difference in nomenclature and kind of the perspective. And frankly, actually, after that conference, I've changed some things up with how I've been treating some of my patients with autonomic dysfunction, and I've had some really good success so far. So basically, I wanted to talk about that a little bit and just spur conversation. This is not going to be a 50-minute lecture. I'm hoping to stick around 15 minutes, talk about some cases, and just like get your perspective. And I think through that, we'll probably end up coming up with a few research questions that maybe we could be thinking about too. As Tay mentioned, he's being very generous by calling me an autonomic researcher because I am not an autonomic researcher, but I did learn a ton at AAS, and I want to give credit to those in the SCI world that have definitely been autonomic experts. And I really attended AAS because of both Tay and Ryan Selinsky, who works with Dr. Wolfgang Singer at Mayo Clinic, and prior to that, Andy Taylor at Spalding. And when I think about an SCI autonomic expert, I would say it's Ryan, and he's the one inviting me to the conference, and we gave a presentation. And then Dr. Korsakov and Dr. Victoria Clayton up in Canada, in British Columbia area, and all their work. So I'm going to mention them a little today too. What I actually research is endothelial cell function related to cardiovascular disease. And you can easily see how that's all interconnected. So my primary interest in my research projects is really that to look at how can we prevent the incredibly high risk for cardiovascular disease that people with spinal cord injury sustain. So it's been pretty well epidemiologically classified that people with spinal cord injury have a 3 to 4 times increased risk of developing cardiovascular disease, specifically heart attacks and strokes, and that traditional risk factors like lipidemia and obesity and these factors are not appropriately accounting for it. So we've been studying endothelial cell function. I'm not going to talk much about it after this, but effectively there's a ton of it. And now we're trying to understand modifiable risk factors which might be driving it, which led me to understanding autonomic function, blood pressure instability. Obviously, that has something to do with endothelial cell function. So I've been learning how to really understand that better. Clinically, I do inpatient service throughout the year, and I have an outpatient clinic where I see patients, and I direct the spasticity clinics. I do Botox and phenol injections and those kind of things. But especially my outpatient, my clinic has become very much an orthostatic hypotension AD clinic or autonomic dysreflexia clinic because there's so much need. And I've had some success because I've been able to think about it scientifically and attend conferences such as yours. And so now I'm getting a little notoriety for that. So my clinic is just filled with orthostatic hypotension for those who do not improve just through natural time. And listening to you all talk about your POTS populations as well, and your people with POTS that you see in your clinic, I think we have some similarities there. So once you build it, people come, right? So just some interesting things that I'd like to share with you as well. So Tay let me know that some of you are familiar with spinal cord injury and some of you are not. So the presentation is going to be pretty brief, just understanding of like how spinal cord injury doctors think about autonomic dysfunction after spinal cord injury and the mechanism. We think a lot about level of injury and those factors. And then I'm just going to go into some observations and treatment paradigms. And I want you guys to, frankly, I want you to rip it apart and tell me what we're missing in the field and how we could do a better job.
Yeah, just like I said in the email, not a lot of people know everything about the spinal cord injury. So if you can, kind of briefly explain what AD is and some spinal cord injury stuff. Just
Yeah.
thank you.
Thank you. Yeah. Okay, so my title is Room for Improvement. That's really the title. So I think this audience is going to have a lot to contribute to that. So the patient population that we serve most here at Craig Hospital is individuals with traumatic spinal cord injuries. That can be motor vehicle crashes and diving accidents and sports-related injuries and violence like gunshot wounds and those factors. But it can also be like ischemic injuries from various things like aortic dissections and all those kind of components. So when we discuss kind of traumatic injuries in general, we are talking about that category. Of course, there are like autoimmune conditions that can induce spinal cord injury directly, things like MS and NMO and other those types of diagnoses. We do see a lot of Guillain-Barré and West Nile virus and those diagnoses as well because it just leads to the same type of paralysis. So that group as well. But specifically today, we're going to be talking about more of the traumatic type of injuries, which give a much more clear distinction of a level of injury. And we'll talk about how we define all of that as well. But from an autonomic standpoint, when we're thinking about spinal cord injury in general, you have a level of injury. You have an area that seems to be the primary traumatic site, radiographic evidence of a traumatic injury onto the cord. And then on top of that, you have a clinical examination, which we'll go over next, that gives us the ability to assess where things start changing for that patient. On top of that, that disconnect that occurs leads to obviously autonomic consequences. And, from a purely neurological standpoint, we think about this decoupling that occurs below the level of injury. And so you have from a sympathetic pathway, there's a clear disruption where you lose the supraspinal control of these sympathetic pre-ganglionic neuron pools. And then that has consequences, obviously, in innervation of the peripheral vasculature below the level of injury, and also the adrenal gland in producing various types of vasopressors and catecholamine responses in that environment. Of course, that has an effect on the baroreflex system, and it's kind of the yin and yang control of the parasympathetic nervous system. And so with the decoupling of the sympathetic system, you have somewhat of an uncontrolled parasympathetic response to the vagus nerve, and that dysregulation occurs where you see profound bradycardia and arrhythmia risk and a significant hypotensive event early on after injury. So, from a timelines perspective, this is what's most paramount early on. So a person with a significant spinal cord injury will have neurogenic shock and will have significant reduction in blood pressure, bradycardia that can lead to an arrhythmia that leads to arrest. And if you find a person with a spinal cord injury, from a paramedic on-site standpoint, most individuals are going to die on site from that and having a neurogenic shock event and not being resuscitated early enough. Now, in the intensive care unit, this is persistent and with varying degrees. Of course, level of injury is important here, and if the higher the level of injury and more severe the injury, the bradycardia and hypotension can be significant enough that you need vasopressor support throughout the initial phase of the injury to sustain circulation in that early period of time. And then naturally over time, you see some improvements in that system. And we don't exactly know all the mechanisms, and the reality is it's probably quite heterogeneous. But some individuals are having some compensatory mechanisms from the peripheral system, as well as kind of a parasympathetic retreat to increase heart rate and try to maintain blood pressure. And then a combination of those factors that occur through time. So as people are transitioning out of the ICU, even with a high level of injury, you don't need persistent compressor support. Adaptations occur, and people have kind of a baseline blood pressure that they can be perfused and not lose consciousness on you. Now, that being said, by the time they come to Craig, which is about 4 to 6 weeks after their injury, now that we call that the subacute phase, they're now starting to attend and participate in rehabilitation. And so, that we can discuss what that really means, but a lot of that from a medical management perspective is optimizing patients so they can participate in therapy. And some of it is compensatory. So we're teaching people how to understand their limitations and give them equipment and power wheelchairs and all the things that needs to be for them to function in life. But we're also facilitating neurorecovery, right? So by preventing complications and really assessing that they had the adequate decompression and things that we know that can improve neurorecovery, people get better in this subacute period of time. We draw this arbitrary line about a year after injury is when most of the recovery will kind of plateau, and I have qualms about that. But this early phase is very critical to understand how much recovery they're going to get. And this is also when we see the most autonomic dysfunction. And so I mentioned the top two, which is kind of the autonomic component, but then related to that, of course, is still autonomic is major shifts in intravascular volume is another big component. We know that with any sort of acute traumatic injury, even if you didn't have a spinal cord injury, you have lots of neuroendocrine disruptions, and then you have loss and suppression of ADH. And so oftentimes individuals with spinal cord injuries have significant amount of nocturia and volume depletion. And so we're kind of combating that in the early phase, and I'll give some examples of that. And then as people are starting to adapt to their injury, of course, they're having significant body composition change. So loss of muscle tissue, loss of bone tissue, and of course, deconditioning and the paralysis itself leads to loss of muscle pump, which again is important to our topic today about orthostatic hypotension. So our kind of understanding is depending on where the level of injury is, you have a certain amount of your sympathetic system that is now denervated. And through that process, all the organs that are involved in that innervation are lost. And we really pay attention to T6, thoracic level 6, because clinically it appears that T6 seems to be this golden hotspot where the individuals become more symptomatic with these types of low blood pressures and autonomic dysfunctions. Most of it kind of credited towards that's generally the area where the splanchnic venous pool and vascular pool exists. And so that's where a large shift of the blood pressures that can occur. So who develops orthostatic hypotension after spinal cord injury? I kind of alluded to this earlier, but vast majority of the time, we're thinking that people with T6 injuries or greater, because of that spike neck vet that I just mentioned, but also this idea of a complete injury. So the American Spinal Injury Association is a group which has developed over decades now this scoring system. So we use the INSCI examination to give us the ability to understand where motor and sensory levels start changing. That gives us the ability to mark a neurological level of injury. And this is quite literally a motor muscle test followed by a sensory test using light touch and pinprick. And then we, based on these numbers, we're able to generate an Asia impairment scale, which gives that person a letter grade. This is one test where you really don't want an A, as I joke, is that an A injury is a motor and sensory complete injury, meaning that they don't have motor movement or sensation below that level of injury. There's special attention put to the sacral levels for various reasons, but we consider an A complete injury and then a D an incomplete injury. And then an E being someone who had a spinal cord injury, but is from a motor and sensory perspective completely intact. Okay. And so, but the problem with this is that we are assigning autonomic completeness based on a motor and sensory exam. And this is one of my friction points in our field where, yes, it does correlate a little bit that if you have a pretty severe injury and you have motor and sensory deficits and you score as an A, you have a high probability of having autonomic dysfunction, but maybe not that highly probable. So Dr. Victoria Clayton and Dr. Korskov have written on this in the past, and really this scoring system is missing a huge portion of people with either preserved autonomic pathways with a more complete injury, or individuals who clearly demonstrate autonomic dysfunction who have incomplete injuries. And so this is one of my fixing points, is that we in the field are pretty bad at predicting who are the people who are going to have autonomic dysfunction and who are the people who are going to have persistent problems into the future. And so what do? Well, we wait and just see who develops symptoms, and then we start treating it at that time. And so I feel like maybe you guys have an opinion on this and maybe could help us be more specific in this area. So that's one question. Now, how do we treat it? And this is another point. You're going to be familiar with many of these things because the world of autonomic dysfunction of POTS and MSA have really created the algorithm that I think spinal cord injury has adopted. But what I can tell you is that this is how I was trained. And then as I ask my fellow SCI colleagues, this is how most people practice, which is that we are algorithmic in that someone has orthostatic hypotension and our therapists are telling us that they're having dizziness. And so everyone with a T6 or above injury, especially the motor complete ones, are going to get compression stockings, abdominal binders. We're going to encourage PO intake of fluid. We're going to do some progressive tilt table in the therapy sessions. And then that happens, and then they still have symptoms. So we give them Midodrine. We give them more Midodrine. We give them more Midodrine. And then after Midodrine doesn't work, we move on to the Florinef and other components. I put an asterisk next to, we have a weird kooky thing we do at Craig, which is we use phenylephrine eye drops, but we put them under the tongue. And it's a great way to get someone to not pass out in the middle of a therapy session if they're just on the merge of passing out. So that's like, again, something we've never really studied, but is a common thing that we do at Craig that I don't think is common in other rehab facilities. I was wondering if that's common in your world. So we use Midodrine, we use Florinef, and then we really stop and say, well, that's everything we can do. So we're going to modify your behavior, limit certain types of therapeutic activities, and then wait a while, because a certain percentage of patients with spinal cord injury will just adapt and will have less symptomatic orthostatic hypotension. It affects their rehab. It affects how intense we can provide therapy early on. And then we adapt by giving them equipment and situations. And then hopefully in a year from now, you won't have these symptoms. And then all the people who don't come back and see me. And then, of course, now the droxidopa has been on only our radar for the last few years. Dr. Joe Wetch is another great autonomic researcher out of Mount Sinai in the Bronx, VA, and she ran a clinical trial showing that droxidopa would make sense in our population. It's being used more often. We're using it more often with some success. Symptom tolerance, we've noticed, has been difficult with droxidopa. But that's about it. And the funny part to me, and especially after attending AAS, is that we don't really do any sort of true autonomic testing to better specify. Obviously, each of these drugs and interventions would target specific components that could lead to orthostatic hypotension. We don't really even measure whether their intravascular volume is down, really in any meaningful way, except to maybe a history and exam, to say that Florin F makes sense in this case, or any sort of testing on, alpha-1 receptor capacity and baroreflex components to say that midodrine is going to work in this case. There's no rhyme or reason except we just try things, and if we keep failing, we go down this algorithm. Okay. So that's my gripe number 2. All right, so some cases. Okay, so this happens to me all the time. So these are the 2 I wanted to present, and I figure we can have some discussion. Is that case 1 is what I call these SCI twins. So, and this is an actual case that happened to me when I was a fellow, which is when I was on inpatient service, we had an admission of 2 patients back to back. And it was a 22-year-old and a 24-year-old male patients who both sustained a C6 Asia A injury, so a tetraplegic motor complete injury. And they actually both sustained it in the same diving accident, so same modality. No previous medical history, no previous other types of conditions. Athletically fit. These were both, they were actually both swimmers prior to their injuries. And so from a spinal cord injury perspective, they were very similar in quality. But throughout their inpatient rehabilitation stay, one developed profound orthostatic hypotension and then autonomic dysreflexia, which is these aberrant blood pressure increases, while the other one did not. And this is what kind of spurred it for me as a fellow to say, wow, we don't really understand why are these 2 individuals with very similar neurological patterns from a motor sensory perspective demonstrating 2 very clinically divergent behavior. The second case is a success story for me, so I like to share it to pat myself on the back, I guess. But we had I have a cohort of individuals with spinal cord injury that are coming into my clinic who have orthostatic hypotension that's recalcitrant to all our treatment parameters. This was a case of a 76-year-old male patient. He has a C5 Asia D injury, is incomplete, has the ability to walk, but has tremendous blood pressure instabilities, which includes supine hypertension and orthostatic hypotension. It started during inpatient rehab, and now he's 3 years out, and we're still managing it. And he has every type of med I just talked about in that algorithm: midodrine, Florin F, PO hydration. He's been salt loading. And a lot of this is also contributing to his morning supine hypertension, but we're just not getting the control from a blood pressure perspective for him to do therapeutic walking. And so he is actually 90% of the time in a power wheelchair, even though he's a D injury. So he has the capacity to walk, but orthostatic hypotension prevents him from being independent and more mobile himself. And so as part of this, what I've noticed was that we don't actually even measure strict I's and O's regularly. So I asked him to do that in this case, and I found out that he was dumping approximately 9 liters of output per day, with 4 to 5 liters overnight on a regular basis. And he was still PO intaking, trying to drink 4 liters a day, but it's just a losing battle that we were sustaining. So based on this case, I went upstairs and started recording more strict I's and O's on various patients with recalcitrant orthostatic hypotension, and found that nocturia and ADH and loss is likely a big driver here. We're having massive intravascular volume loss. And there's a lot of gray area here that I'd like to talk about, but your clinical symptoms are almost useless, right? So generalized dizziness, dry mouth, peripheral edema, all these things just are constant and prevalent in people with spinal cord injury. So a lot of the traditional factors that we look to see if there was intravascular volume loss isn't just useful on the floor. So far that this is what I've been seeing the most. So he's actually been really responsive to morning water fluid bolus. So I found some literature in your world within drinking 600 to 700 liters, milliliters of fluid rapidly in the morning, and that can cause a sympathetic response that leads to increase in blood pressure. So that's been really helping him get out of bed. And then we've been doing an elevated bed. and keeping his head above for a period of time to try to reduce the hydrostatic influence in nocturia. And we've seen his overnight nocturia decrease to about 2 liters overnight, which has been much more manageable and has worked better than any of the medications I threw at him earlier. So thank you guys for your information. So, okay. So just to say, I talked a lot of negative things about my field, but to say we are trying as a field, I just don't know if we're doing a good job. This is an example of a kind of an INSCI plus where we're trying to standardize the measurement of autonomic function in people with spinal cord injury. And it's heavily borrowed from components from the autonomic world. And I will say this has been distilled significantly because there was a lot of resistance in our field about all of the complex measures that may be required. So it's okay. And we're trying to do it, but frankly, no one is really doing it in the field yet. But we're trying to collect better data to say that we should be measuring components of autonomic function. I will say that this was much more robust in the past with looking at sexual function and other components as well, but it's been whittled down to this at this current state. There are also people I've mentioned, like Ryan Selinsky. He is much more trained in the world of autonomic testing, and he's been doing some interesting work in identifying kind of these supralesional and sublesional types of activation of the sympathetic nervous system. This was a cool Z-score system that he created using this plot to demonstrate that these individuals who have similar injuries autonomically look very different from each other, looking at things like Valsalva maneuver versus phenylephrine boluses versus a cold pressor test above the lesion on the hand or below the lesion on the foot, for example. So these individuals in our minds would be the same, and clearly it's not. And then Dr. Victoria Clayton and Dr. Andrew Korsakov at the UBC, and Simon Fraser, that is, have been doing interesting work using heart rate variability and blood pressure variability to assess the idea of, at least maybe we can dichotomize the idea of a neurologically complete versus a neurologically incomplete individual using things like baseline norepinephrine testing and using these variability markers as well. Okay. One thing in the world of spinal cord injury, I know Dr. Aaron Phillips has been to AAS in the past, but this is how we're trying to treat autonomic function, which is we're going to hammer home the sympathetic nervous system. And so we are in the works of using what's called spinal cord stimulation. And Craig Hospital has been very involved in the implementation of transcutaneous spinal stimulation for motor and sensory recovery, and has seen some good results. There's an FDA-approved device that we helped launch. And now we're moving forward with an implanted device that's specific for hemodynamic control. So this is like a pain stimulator that you would see in a pain clinic, but that epidural lead is placed in the mid-thoracic area that's been identified as an area that can induce blood pressure increases sympathetically. And we're going to try to modulate blood pressure using these devices. So I'm a co-investigator in this study, and we're hopefully going to launch here at Craig very soon. But what I see the somewhat a hypocrisy in my part is I just made an argument that we are maybe missing some fundamentals when we think about spinal cord injury in both assessing and understanding and predicting who has autonomic dysfunction and what the precise treatment for that individual might be, depending on medications or volume and all of these different components. And while I have that in my mind, we're going to just hammer the sympathetic nervous system more and see if we can fix this problem. So that's kind of where I am in the field, and it's been really great learning more and getting information from you all. So I'd love to open it up to discussion and see what you guys think. Thank you.
Great. Thank you so much, Andrew. That was a really fascinating, thought-provoking talk. I think there's some kind of comments and all that, but Jeff, you want to go first?
Sure. That was a really lovely talk. Thank you, Andrew. And thank you for the summary for those of us who don't see spinal cord injuries. I'm a pediatric cardiologist, so we see a lot less even than you probably would from the adult side. A few comments. Number one, a potential therapy that you could also use for increasing intravascular volume is desmopressin. I don't know if you've tried that before. But zero point 0.1 to zero point 0.4 milligrams BID has been really helpful in, especially in patients who don't tolerate Florinef or Midodrine, from that standpoint.
Yeah, in fact, I had this discussion at AAS because, especially for the patients who are having high, clear, obvious nocturia at night, we do use this desmopressin, but oddly enough, not for this patient population, not for people with orthostatic hypotension. A clinical scenario we actually use it for upstairs is that we have patients with paraplegic injuries who are about to start IC, do intermittent catheterization. And the nocturia in this population, which has far less orthostatic hypotension events, but they're having a hard time cathing enough times at night to keep their bladders empty. And so they're having to get up every 2 hours. And so for those patients, we're using desmopressin to try to lower their nocturia so that from a sleep and quality of life perspective. But oddly enough, in patients with tetraplegic injuries, vast majority of them will still have an indwelling catheter, or a suprapubic catheter will be placed for long-term management. And so what we found was that we were just having the nurses dump out the urine every single night and not really measuring how much was coming out. So we never really thought about it from a vascular perspective. So I have been using desmopressin upstairs, and I agree with you. I think I've seen some good results with that. I did have one time that I had an individual who was much older, lived in the Western Slopes, and I put her on desmopressin. I threw her into hyponatremia. She
Yep.
ended up in the ICU for a while. So
Yep. I've had a couple, three patients before I was really strict about sodium intake,
mhm.
have hyponatremic seizures. And so I definitely make sure that the patients are strongly aware that they need to be taking in 8 to 10 grams of sodium chloride on a daily basis.
8 to 10 grams. Okay.
Yeah.
That's super helpful. That's a lot more than I've been prescribing.
Yeah. Another question, how low is the bradycardia in these patients?
Absolutely. So early on in the ICU settings, can be down to 20 or 30, in which
Yeah.
case we'll just,
Yeah.
go down. As they adapt, kind of the baseline bradycardia at resting situations, we see down into the 40s where they're
Mhm.
still asymptomatic, enough that sometimes they come over on cardiac tele, and we're just monitoring them forever. And frankly, we had kind of these patients come from all of these different types of trauma centers, and they get to us. So some of these individuals will already have a pacemaker implanted before they even get to us because they're having asymptomatic but persistent bradycardia, normal sinus. But yeah, down to the 40s.
Reason I ask is because, as I'm sure you can guess, having that significant bradycardia can lower your cardiac output, which can add to your orthostatic hypotension. So, a potential medication before getting a pacemaker put in is glycopyrrolate, actually.
Mm, mm.
And I believe max dosing is 8 milligrams divided TID. And it's interesting, I've had a few POTS patients, as you can imagine, again, the large majority of POTS patients are tachycardic. And with that tachycardia, you also have a decrease in cardiac output. And so what we'll do is we'll use low dose propranolol or ivabradine to slow the heart rate down some to prolong diastolic filling, improve cardiac output, improve cerebral perfusion. But in the opposite direction, the same is probably happening as well.
Yeah.
And so increasing their heart rate, their baseline heart rate with a little glycopyrrolate might be able to give you a little bit more of a boost.
Would
That's
come at
super
the cost
interesting.
of constipation, and then there's a real risk of worsening the autonomic dysreflexia because of the bowel filling. I'd be really careful about glycopyrrolate.
Yeah, I mean, I would start slow, start low. I mean, but the goal is just to maybe get their resting heart rate into the 60s. I mean, you're not trying to push them super far. Um, and
Yeah.
then you
Just
already
to comment
mentioned,
on that, just because the other component is that when people get to Craig early, we see that bradycardia, and then we have two dichotomous groups where people stay bradycardic or they become tachycardic.
yeah,
And we think that that's compensatory. And we actually have a lot of younger patients, kind of like the adolescent, like 16 to 16 to 18-year-olds with paraplegic injuries who their heart is just beating at like 110 beats per minute persistently, asymptomatically. They don't have orthostatic hypotension, but we think that's compensatory due to the fact that they have vasodilation, venous pooling. They can just compensate enough so they're not symptomatic. And I worry about those patients because they have this compensatory mechanism, but what does the heart do after beating like that for another 20 years? So
Yeah.
yeah.
Yeah. And then my last comment is you mentioned that 1 year kind of break point. I don't know if have you seen the book My Stroke of Insight? It's a book by a former Harvard neurophysiologist who had her own stroke. And, what was told to her also was that sort of 1 year is what you see is what you get. And what she found is that's not exactly true. There's still significant neuroplasticity that allows for continued improvement. I think that 1 year mark, it sort of slows down, but it took her about 8 years. Yeah, Jill Bolte Taylor. Thank you, Nicole. It took her about 8 years, from what I recall from her book, but she felt that she got back to much closer to normal than had she just sort of given up on that one at that 1 year threshold. I'm curious if you see the same thing with spinal cord injury.
100%. And as one of the sites, we have the spinal cord injury model systems, and it's been around since the 70s, and we collect all of this data, and that's where all the normalizing epidemiological data has existed. And based on that that's where that 1 year to 18-month mark was created from, is that we see a plateau in the INSPI scores. And there's so many problems with that, mostly because we collect that 1 year and then we don't collect again until 5 years. And then the numbers go from 10,000 to 1,000 because there's a lot of attrition that occurs throughout that period. So the data is poor. But even if you look at that data, you see this massive bell curve. It's just a very classic bell curve. There's clearly people who are continuing to get neuro recovery and people who had plateaued much earlier. And then somewhere in the middle is where there's a majority. But I 100% agree with you. I think, very much this is one of my soapboxes, so I'll make it quick. But what we see is it may not be neuroplasticity, right? Like we are measuring neuro recovery by a motor and sensory exam. And so there's a critical step there, which is even if there's neuroplasticity, the musculoskeletal system has to be intact for us to measure neuro recovery. So from a neuroconnectivity standpoint, the person might have an improvement, but if they have a contracture in their hand, you're still not going to measure function. You're not going to measure a motor response, and we're calling that neuro recovery. And I can tell you back in 1970, we were pretty bad at managing spasticity and encouraging therapeutic walking and doing all the things we need to do to maintain musculoskeletal health. And so I can give you 100 examples of people who are coming back to Craig every year to get their annual exams and who have clear and obvious neuro recovery 10, 15 years out from their injury. But they're all the ones who are able to stay out of the hospital, not get sick, and continue some sort of therapeutic movement program that prevented contractures and kept muscle health. And they kept seeing improvements. And of course, completely divergent in what those patterns look like over time because we're not very good at predicting that. But we are using antiquated data to draw this arbitrary line of 1 year. So I give the spiel a lot to my patients. It's like part of the plan is, get healthy in the sense of prevent complications. And that's a lot of what you do early on in inpatient rehab, but then come up with a therapeutic recovery program that's focused on musculoskeletal health and preventing problems. And if you do that, once in a while, you see this blip of improvement, come back, do an intensive with us to, really maximize these things, get your equipment changed, upgrade things, and then move to your new program. And, it's really an athlete mentality. But if you're doing this progressive process, many people with spinal cord injury continue to recover into the decades.
Thank you.
And Dave.
Yeah, thanks very much. I see that Chris Mathias is on the call, and good to see you, Chris. Chris, many years ago, I think was one of the first to emphasize the catecholamine abnormalities in quadriplegia, and we recently replicated and extended on those findings. I think they're important. for understanding mechanism and treatment. So if I can share my screen, I'll show you what I'm talking about. Can you guys see the screen?
Yes.
Can you see the screen? Yeah. Okay. So this is kind of a diagram of what happens, and with high spinal cord injury, as was mentioned, the innervation, at least the parasympathetic innervation of the head is intact. Presumably, the sympathetic is going to be screwed up. But the idea is that both the sympathetic noradrenergic system and sympathetic adrenergic system are going to be impacted because of the placement of that lesion. So this is what we found, and this is a study that was done in collaboration with the people at the University of Louisville, who are big fans of dorsal spinal cord stimulation to alleviate orthostatic hypotension. And the long and short of it is that works, but a lot of room for bias and so forth. But there's no room for bias when it comes to what did the catecholamine levels look like. And in the people with spinal cord injury, normally they have low norepinephrine levels. Normal, you can see, is up here somewhere. So they do have this very straightforward biomarker of the sympathetic noradrenergic lesion, pretty much exactly as Chris described a generation ago. Epinephrine is a much more difficult topic because the levels are low anyway in people, and you can see, at least in this study, epinephrine levels were actually a bit higher than in the healthy volunteers. So there's
I'm
kind of a
sorry, can you make it
discrepancy.
bigger? Can you make it a little
Bigger?
bigger?
Yeah,
Yeah, it's
sure.
really hard to see. Sorry to interrupt you. Yeah, much better.
Oops,
Thank
sorry.
you.
I screwed that up. Where are we? There, can you see that?
Yeah, much better. Thank you.
Okay. So that's one thing. There's kind of a discrepancy between the pure neuronal and what I think is a kind of a mixed neuronal and hormonal regulation of uh, uh, of epinephrine secretion in the adrenal medulla. If you look at the response to tilting, it's clearly blunted, and it's blunted in terms of norepinephrine and epinephrine both. So and you can also see that let me just if you do the spinal cord stimulation thing, it really does there it is. You can see that there is a catecholamine response to the tilting that you don't see without that stimulation. Very dramatic, I thought. And it was one you can see also here that this is with the stimulation, this is without, if I remember right. But the idea is that the norepinephrine and epinephrine are related to each other. And that's not too surprising, given that what we're talking about is two kind of distal measures of the same proximal lesion. And the last thing is I think, yeah, this is just the changes. And you can see there's a very nice improvement of the norepinephrine response to tilting with that spinal cord stimulation thing. So my questions are, let's see, how do I turn this off? Not sure how to turn off the sharing.
There's a little red button on the top here.
This?
It would be an overlay on your Zoom.
Yeah.
overlay on Zoom.
It's right there on that tab you just opened. It says stop sharing. Just scroll down on the red words. It says below that. There you go, right below the picture.
Dr. Goldstein,
there. Sorry, my
was,
goodness. Sorry about that. It just screws me up every time. So the two things are there is a biomarker of the at least the sympathetic lesion, exactly as Chris described a long time ago, and there also is this idea that that spinal cord stimulation. I'm not sure how it happens, but spinal cord stimulation will allow for a return of that catecholamine response to the tilting. So it's something to sort of put in your head. Why spinal cord stimulation would do that, how it happens, I don't know, but the data are pretty clear.
Thanks, Dr. Goldstein. And I would say I've read a lot of your work, Dr. Goldstein, Dr. Mathis as well. And so nice to meet you in person. And I 100% agree. I think that I know Ryan Slinsky is also very interested in norepinephrine levels. And I know that Dr. Clayton has also done work in that area, looking at basal rates and then response to tilt table. And so I do think that could be a useful marker. And I even noticed in your cohorts, I'm assuming those are groups, obviously they had orthostatic hypotension. I know the Louisville group implanted these devices for motor recovery as well. And but even in that cohort who had orthostatic hypotension, there's a decent spread, right? So clearly still significant.
That's right.
But that heterogeneity, I think, is the key piece, is to categorize those cohorts and figure out who are the individuals that may be intervention. And
right, and whether there's a relationship between the skeletal muscle control and so forth, and the autonomic is just wide open. I don't think they studied that.
And I've never seen actually the norepinephrine epinephrine difference. So that's very interesting, because there's a recent set of articles published out of Ohio State, and they look at a lot of the effects of sympathectomy on the spleen and how it affects the immune function. But they did a series of studies that showed that after a spinal cord injury, they can demonstrate that the adrenal gland, right after a spinal cord injury, has this massive cytotoxic catecholamine release of both of glucocorticoids and cortisol and all of these different molecules that go into circulation. And when they did an adrenalectomy,
not surprising. Not surprising, because of that hormonal regulation that's special for the adrenal medulla. Special. Only the adrenomedullary cells are bathed in a humongous amount of cortisol. Only them. The sympathetic nerves, nothing. That has nothing to do with the sympathetic nerves. The adrenomedullary cells are constantly bombarded with cortisol. Cortisol is trophic for PNMT, the enzyme that converts norepinephrine to epinephrine. And so it's not surprising that there's in a situation where there's a tremendous amount of cortisol, if anything, there'd be an increase in epinephrine.
Yes, and what's so interesting is that they did a series of studies afterwards where they did an adrenalectomy prior to giving that mouse spinal cord injury. And obviously they didn't see the catecholamine response. But those mice had almost normal muscle and bone physiology versus the non-adrenalectomy mice who had significant atrophy. And in the field of spinal cord injury, we've always thought of bone and muscle loss is because due to disuse and paralysis is a direct neurological consequence, but it actually might be mostly neurohormonal in that mechanism.
Yeah.
So I know they're doing a series of studies now which have demonstrated that maybe this persistent adrenal overactivation is occurring in a subset of patients, and I wonder those are the ones you count who are more.
I think that Clayton's devil's advocate kind of view about the spinal cord stimulation thing is maybe what you're doing is in a very subtle way over many weeks, months of training. This isn't just stimulation alone, but in the context of a lot of PM&R kind of stuff. Maybe what happens is you get a subtle autonomic dysreflexia that you can control. And I thought that was really kind of an interesting one. I don't know how the spinal cord stimulation thing works, but maybe she's right. That
and there are clear.
You're learning to control autonomic dysreflexia.
Yeah, and it becomes a definitional problem. I will say there are hardcore camps forming in this area right now regarding this, because when you use the term AD, it is very negative context for good reasons, a triggering word. And some people would argue that if you have a blood pressure response that you induced and controlled, by definition, it is no longer AD, because AD is uncontrolled blood pressure. But it is definitely still a noxious stimuli you're applying below
an example of two
injury.
wrongs make
It's
a
increasing
right.
Exactly. So it becomes a bit definitional, and it's all. I think one prevailing theory is, which has been consistent in the world of motor and sensory control. So we were part of the Uplift trial through Onward, which used a transcutaneous device to improve motor and sensory function of upper extremities. And the prevailing theory in that mechanism is that you have these residual bridging tissue through the injury site in areas. And there might be a pool of neurons that are not really engaged in normal normal transmission of signals after your injury. But when you apply this current that's clearly going through the dorsal root ganglions, accessing through a sensory pathway, and kind of increasing excitability is a term that's talked about, which means that these neuron pool that was previously not engaged is now sensitive enough to take a weak signal of the injury and drive a response. And clinically, we've implemented these devices here, and I would say we're one of the few that have bought a ton of these very expensive machines. And we can take a patient who had a certain motor component, and there's a subset of patients, you put the pads on and turn on the machine and do the parameter setting, and they instantly have more motor and sensory function. Instantly. Even in people with decades out from their injury. Now, that's a small subset. And there's another group that you now do this with activity-based practice or therapy, depending on what cohort, and just repetitively try to repeat the control of the stimulus you're interested in. So if you want to use your hands, you got to use your hands with the device on. And even decades after injury, plateaued from traditional therapy, demonstrate new recovery. And then again, another cohort that after you do this repetitive training and you turn off the devices, that they retain some of that function. And apologies for doing construction here. And so there's quite a variety of patients. And that's really where the field is interested in is who are the responders, who are the non-responders, and how can we better predict this? And in the world of blood pressure, one group thinks that that's what we're doing. We're increasing this excitable pool, which allows more of the supraspinal control to get through to regulate sympathetic response from an autonomic perspective. The problem is that we're not doing a great job of measuring, step by step the mechanistic components to really understand that. We're turning on stim and we're measuring blood pressure. We're asking people how they feel. We're not really doing the mechanistic work. And, I'm being a little obtuse on purpose. There are definitely people interested in that. But there could be more people in the field that really should be studying those underlying intricate mechanisms that exist in there.
Well, you have those distal biomarkers that are sensitive. The only hassle in this is that the levels especially of epinephrine are crazy low. And that means that you can't rely on a commercial lab, because a commercial lab is only looking for rule out pheochromocytoma, something like that, and so they'll report normal, and it's not in this context. That's not going to be helpful at all. So
are you using like
you need an
mass
assay that's sensitive. I'm sorry.
Are you using mass spec? I was kind of looking in this world and these.
Yeah, that's an interesting one, topic for another day, I think. But basically, what I showed you was liquid chromatography with electrochemical detection. Electrochemical detection is very, very sensitive because catechol spontaneously oxidize them. They're very, very susceptible to oxidation, and you can measure current with exquisite precision. So no problem with LCED, except There isn't any lab that does it anymore. The electrodes are not available anymore. I have systems that I'd be happy to give a lab. They work, but our lab is shut down. So the systems are there, and the electrodes are not commercially available elsewhere. LCMS is also very, very sensitive if you know what you're looking for. In this case, you are. And I think that is the future. But I don't know if commercial labs pay attention to low levels because they're being paid for ruling out pheochromocytoma.
Thank you. Yeah, that's very interesting. I think that I know Dr. Clayton has done some work in that space, and the question is the clinical implementation piece. I think, one just plug is that at Craig, I run a biobank here. So I've been banking human samples for people with spinal cord injury for the last couple of years, and somewhere around 400 individuals have been banked, and we serially follow them so far. And so these are
samples of what?
Serum and plasma currently.
Really?
And yep, with the goal of expanding to other types of things as collaborators.
With tilting?
So no, we do not. These are kind of serial samples throughout their inpatient rehab and things like that. But these are the kind of collaborations I'm looking for, because we could absolutely be doing that. And obviously, we're part of the Onwards Empower BP trial. So as part of that, we'll probably be biobanking samples from individuals.
Well, I'm thinking seriously about setting up a commercial little lab that would do the MS tandem MS spec. I'm only off by 2 decimal points in terms of setting it up. Yeah.
Okay. Yeah. We'd be interested. We worked with some commercial startups on things like oxidative stress and these types of markers in the past. So we've given samples to help do validation work.
There is a commercial lab, ARUP, ARUP, that does catecholamines by LC-MES spec. I don't know what their sensitivity is and so forth and so on, but they're in Salt Lake City, if I remember right. You may want to get in touch with them. ARUP.
I'll definitely look into that. Yeah.
Do you tilt those patients in the lab? I mean, how do you tilt the spinal cord injury patients? It's gonna be hard.
Yeah, so we do have tilt tables, and we use them clinically. So we do a graded tilt table to try to increase tolerance. We have some tilt tables that provide leg pump, with FES and those kind of things, and it's more of a therapeutic tool. But this is, and Tay knows this, that I came because I think the field of spinal cord injury needs to be doing more formal autonomic testing. And this is kind of one of Ryan Slinsky's his points, is that I think we have some very low hanging fruit here to better take this heterogeneous population and put them into more therapeutic groups.
So I agree.
So a tilt table, we should be a Valsalva maneuver, some cold pressor tests. If this was part of the normal mantra, I think we'd have more precise treatment algorithms for our patient population, as well as all of these new interesting things like epidural stimulation coming out. I'm going to keep coming and listening and seeing what we can do and try to establish some of that. So I would say I have a tilt table, I have a Finepress that I am learning. We do have some equipment and investment, and so look forward to learning more from you all. So thank you for your time today.
Yeah, well, thank you so much, Andrew. Any other quick comments or questions? I guess, Andrew, you probably have to go to patients. So.
May I? May I?
Yes, yeah.
Well, I'm really sorry that I missed your talk, but I'm afraid I got tied up, you see. So I hope it's being recorded and we can have a look, listen to it again, you see. But coming back to some of the comments, intrigued about the spinal cord stimulation, and that helps, I assume, orthostatic hypotension. Would that be right?
That's correct. That's correct.
So it's really very similar to, in a way, inducing autonomic dysreflexia in a minor way, by either muscle spasms or bladder stimulation or cutaneous stimulation below the level of the lesion. And that's really useful in terms of helping those patients who run into problems. Now, the other thing we found was, and I fully agree with But sorry, I can't disagree with David. Let's put it that way. Who's done so much work in so many ways. But I'm going back to the early 70s, 73, when in fact we had to turn to Niels Christensen in Denmark, who had the liquid chromatography assay, because in the UK there was no one who could measure these levels. And fully agreed, David, the levels of noradrenaline and adrenaline are subnormal, pretty low, as it were. Now, what is interesting is with tilt, when the blood pressure falls, the noradrenaline levels and the adrenaline levels do not rise, as you'd expect, because there isn't any sympathetic spinal stimulation. But, and what intrigued us, was that the levels of renin and angiotensin II rose. And a little later, rose the levels of plasma aldosterone, which, as you know, is activated by angiotensin II. And this made us think about whether these techniques of repeated tilt may be of benefit in terms of elevating renin and other levels and keeping their blood pressure up. But we never did go into that. We were really onto the mechanisms, as it was. I think that's the word you use, or mechanistics, isn't it, in terms of this. There's one other point, if I may make, I've got half a minute, that these levels of noradrenaline in particular, I'm sorry, we don't use epinephrine here in the UK. I apologize for that. But I think you understand what it is. The levels of noradrenaline...
Just need one more revolution. That's it.
The levels of noradrenaline rise, but only marginally with during autonomic dysreflexia, which intrigued me at the time, because I was doing my thesis at the time, as to why this was the case. And so we managed to get the ethics permission to infuse noradrenaline. And what was clear was that they are super sensitive to noradrenaline. So if you look at the response in a normal subject versus them, they're far, far greater. So yet another thing to keep in mind, as it were, in these studies. But I'm coming in from the outside without hearing you, so forgive me if I'm going off tangent.
No, this is perfect. And actually, I've read a lot of your work, sir, and I'm my actual primary research, and maybe we need to break, but there is I'm interested in endothelial cell function as my primary area, and I came in from...
Sorry, can you repeat that?
My primary area of research is endothelial cells.
Oh,
and vascular endothelial cell mechanisms. And I was coming in at the angle from cardiovascular disease and the prevalence of developing atherosclerotic disease. But in that journey, I've ended up in the blood pressure and autonomic space and assessing that. And to me, it makes complete clear sense that if you have autonomic dysfunction that leads to a sympathetic reduction that leads to a blood pressure response, the local endothelial cells would do everything in their local power to induce vasoconstriction to try to perfuse the local tissue. It's feeling the ischemic effect in the local environment. So it's going to drive up endothelin 1, reduce nitric oxide production, and desensitize to muscarinic receptors and increase sensitization to alpha-1 receptors, because it's trying to induce as much vasoconstriction, understanding that it's not getting a sympathetic backlog. So the smooth muscle is now under endothelial cell control. And so I think you're on this hyper local hypersensitized environment. And so I think that there is a subset of patients who don't even have orthostatic hypotension, but are set up for atherosclerotic disease because their endothelial cells are compensating, but it's inducing an environment that's very atherosclerotic.
You have to be a little bit careful about the infusion data, because these people, of course, have baroreflex sympathoneural failure. So they're going to be sensitive to norepinephrine in terms of blood pressure responses anyway.
Yeah, I think it's definitely multifactorial, and I think there's going to be heterogeneity even in that group of what is the magnitude or effect size of the baroreceptor central mechanisms versus peripheral mechanisms.
Yeah.
But
yeah.
I think that there is a endothelial cell mediated component to how AD is being produced, because all of this local tissue below the injury is now hypersensitized to that environment. And you don't need a catecholamine. You just need a noxious stimuli below your injury to induce an inflammatory response. And those endothelial cells can react to that local that environment. And so I feel like I need a better grasp of how to get a sense of the autonomic phenotype of our patient population, and then we can couple that with our endothelial cell markers to start kind of deciphering these components. And why I'm interested is there's things we can do to endothelial cells directly to improve their function that I think could be helpful in this environment of orthostatic hypotension. But we're kind of in our infancy in trying to understand that.
Andrew, do you have a few more
Yeah, I
minutes?
do.
Or
Actually,
do
this
you-
was great. I'm having fun.
Because
So.
we're being conscious of your time. Spillan, I'm sorry.
Yeah, I want to add to exactly what Andrew is saying about this research. The endothelial research is happening also from long COVID angle because those are very important topics. And I'm also interested in the same thing. I'm a neurologist, because when you look under the microscope, endothelial cell is in direct communication with a small nerve fiber and in direct communication with mast cell. So don't forget that there are more layers. Like we want things to be simple. And like you, I started out thinking that exactly what you said, the autonomic control, the vascular wall, the endothelial cell, but there are other players. And these players are mast cells that release, 300 or more mediators, pro-inflammatory. And another one is small nerve fiber, which can be, correct me if I'm wrong, but I think there is evidence of small fiber neuropathy in the spinal cord injury patients from the central degeneration leading to the damage or dysfunction of the small tiny nerve fibers. So I think the picture is very complex. And at the end of what do we look at for patients? We look at them for small fiber neuropathy. We look for immune mediated issues like have you seen that have you noticed that your patients are becoming more allergic or intolerant to foods?
Interesting. Yeah.
And they have and also obviously their neuropathy, which you can't feel below, but do they have altered sensations above the intersection? So many layers apply from dysautonomia to mast cell to long COVID to spinal cord injury that we need to be in each other's fields 100%. So thank you for your research on that.
Well, thank you. Yeah, comment to that is that before I got into endothelial cell function, I was very interested in immune dysfunction after spinal cord injury. And there's clear evidence that after spinal cord injury, there is a subpatients who develop autoantibodies to peripheral nerve tissue from loss of spinal cord blood-brain barrier. And then there's clear evidence of anti-myelin basic protein and all these components. So, and then when you look at the symptomatology of spinal cord injury and all of their general symptoms, fatigue, skin issues, blood pressure, all these things. In some ways, I think we're looking at a Venn diagram with a bunch of gray areas of overlap and probably some underlying mechanisms. But regarding that peripheral component, what I see is a autonomic nervous system, smooth muscle, endothelial cells, and then everything else that's happening from a circulatory standpoint and from the end organ that's innervating that environment. So I talk about like smooth muscle sandwich. Like you need to you need to contract the smooth muscle to create peripheral resistance to generate preload to cause blood pressure change. So any one of these mechanisms could be playing a role. And I bet in our patient population, some are more autonomically driven and some are more endothelial cell driven. And there's a heterogeneous group here, but each of these things could have a different treatment parameters that could optimize these individuals for their care. So trying to tease out these mechanisms yeah, I'd love to continue the discussion. And
what do you guys use? Do you use anything for endothelial dysfunction? Because a lot of my colleagues in long COVID, they say treat endothelial dysfunction. And I'm like, what exactly is it? Some European countries have medications that are designed to open up tiny blood vessels or they're, for smooth muscles. We don't have them in the US. Do you guys use anything?
So not in a direct way. So I'm stating the obvious, but exercise, right, is the number. It helps everything, and both from the autonomic standpoint, endothelial cell standpoint. So I prescribe a very slow, progressive therapeutic walking or cardiorespiratory program using VO2 max parameters to help people, and it's incredibly slow. But I think that has been the best way for me to get people's blood pressures better controlled. that's clinically available. And then I just got a small pilot grant to look at statins because statins have two pathways, but the major one is to improve endothelial nitric oxide synthase availability, which to induce more nitric oxide bioavailability. But that's not it's not going to be the end all be all, because you don't necessarily want nitric oxide as a vasodilator in that environment. And so there's actually some evidence that people who take statins have a little bit more hypotension. And so who and how that's the critical piece. But there's statins have a pleiotropic effect on the reactive oxygen kind of environment in that environment, and can make endothelial cells more robust. And functionally, I think that's going to be really important in spinal stim, because if spinal cord stimulation is inducing more sympathetic drive to the smooth muscle that's normalizing blood pressure, it means that the endothelial cells can now function more regulatory rather than needing to be the primary driver of vasoconstriction. So it can actually be more modulatory in that environment and have more nitric oxide bioavailability. So I think that's actually the mechanism. And so maybe I can next time or a different time I can bring up, I have some pilot data that shows we've done some TSS, transcutaneous stimulation, boosted people's blood pressures, and done our endothelial cell measures where we infuse drugs and measure forearm blood flow change. And we can have an immediate effect based on that. So we think this interplay, that smooth muscle sandwich situation, that's kind of our theoretical model we've been trying to work on to understand all these components. But
do you think exercising below the level of injury may even help further? Because there's such a thing as a functional electrical stimulation, so contracting the muscle that's paralyzed and may, have some additional benefit to it, right?
And that's exactly what I do. Is above the injury is good for various different things, but most people with spinal cord injury, when they exercise, they're doing resistance training and high interval training because they're trying to increase exercise capacity for function. They want to be able to do transfers easier. They want to be able to push their wheelchair faster. Many people are not doing cardiorespiratory exercise where they're just doing slow, low grade kind of endothelial or metabolically focused types of programs. And so doing that, I think, has been the most beneficial. And we use like therapeutic walking with exoskeletons, FES spikes, New Step is another device, and all these different stimulation systems. And then a lot of our incomplete injuries still have the ability to do some of these stuff, but they need equipment to have the longevity, basically, because there's a lot of muscle type fiber changes where they fatigue very quickly. So not another topic, but I think exercise is underrated. And frankly, in the face of not having any real medications to help, it's what I've been kind of hammering in clinic.
I know we're way past time, so I'm not going to start a whole new conversation, but I want to say I love this. I hope you can join us again on a more of a case discussion call, because we didn't even talk about, I mentioned this briefly the first time we met. I see in a subset of SPOTS patients that they have this like mild autonomic dysreflexia. Not the same thing as spinal cord injury patients, but I have had it. If I am wearing a tight lower body garment that's uncomfortably tight, I get a horrific blood pressure spike and a headache. And it's like an autonomic dysreflexia. And when I emailed Tay and Chris Mathias about this yesterday. I take beet juice to get rid of it. That's my nitric oxide kind of vasodilation. Try to, so there's something there. And I'm not the only patient. We have a patient who was a national Taekwondo champion, and he got POTS after a kick to the neck. He got a bad injury, but he didn't have a severed spinal cord or anything like that. He like a bruise, I guess, of his spinal cord, but he ended up with POTS, and he gets this autonomic dysreflexia too. So I know a lot of patients have. It's never been studied or documented. I want to ask you, you don't have to talk. I know we got to go, but how would you document that in physiological testing in a spinal cord injury patient? And can we do like a study on POTS patients who seem to have this kind of presentation?
I think that's a great point. And going back to Svetlana's comments, with AD, we see a lot of symptoms that are very mast cell kind of symptoms, right? Like they get very histamine kind of a response with flushing, itchiness, and in general, like perfusion and blotchiness in the skin. And that's usually the number one sign that a lot of our patients note as the early sign, like, oh, okay, I need to check my Foley catheter. Is it kinked? Is my leg turned funny? Is something getting some pressure below the injury? So it's these more subtle symptoms that people get really attuned to. and then they do something, like, to get rid
Yeah.
of the extra stimuli, and if they can't, it's exactly right. So so the way we measure it is we have something called the ADF-SCI, which Dr. Korsakev and Dr. Clayton had used in the past, and it's a series of survey questions that look at autonomic dysreflexia and orthostatic hypotension symptoms. It's quite long and has a lot of components, more of a research tool. But they just came out with a short form as well. And it just documents kind of those flushing symptoms, cold temperature regulation stuff, all those different kind of components. So that is part of the biorepository. We're collecting that on everyone because we think it'll have value when we start looking at things. But that's more of a patient-reported outcome type of measure.
Yeah, I feel like in POTS, they have so many of these symptoms, it doesn't really distinguish it. But almost like, and also I think a lot of doctors wouldn't believe it that it's happening in POTS patients. So I think we need like a clinical physiology study where we're causing a noxious stimuli below whatever spinal segment and seeing if something happens.
And actually then in that case, Michelle Trobich, who was the other speaker at AAS with us, she does a lot of work with using I'm going to misquote her, I apologize. Basically, cameras that can pick up infrared signal to look at thermal regulation changes above and below lesion as a way to measure cutaneous skin flow. And then she does some things like with EndoPat, which is a device for skin that that measures endothelial cell function. Those components. So there's been some good studies doing that. But I wonder if pseudomotor testing would be the way to do that. Right. And that's as much as I know about pseudomotor testing. But like I think that like that it could be interesting. You'd have to induce the AD. In spinal cord injury, it's relatively easy. We just usually infuse bladders and cause some bladder distension, and you will get an AD response. And so but I would say that there are many in this room, and then I would also just pitch Ryan Selinsky as a person who's doing this a lot from a scientific standpoint.
I want to add there that you don't need to have a transaction to have exactly what Lauren says. You can have full bladder, you can be very constipated. A lot of the times my patients report issues right before they have to go to the bathroom, during or after. Syncope on the toilet or right after is not uncommon. So yes, I think we are talking about similar things, not exact. But the downstream pathophysiology might very much intertwine because it activates the autonomic nervous system. Like I always say, when I give lectures to my colleagues in neurology, I list what can cause autonomic, dysfunction. I don't even call it dysreflexia to avoid, you can have a stroke at the brainstem. You can have a spinal cord injury. You can have CIDP or, Guillain-Barré syndrome. And then you can have all kinds of other things, autoimmune, post-viral, post-infectious, post-concussion. I think we are at the same, at the end of the day, we're looking at the same pathway. We haven't figured it out. And that pathway involves the brain, the spinal cord, the small nerve fibers, the endothelial cell, the mast cells, the connective tissue. Also, we should mention that people with hypermobility and abnormal collagen are going to have a lot of other things that healthy people don't have. So once we get that same pathway, I think we will solve a lot of neurologic, autoimmune, inflammatory, immunologic disorders.
And I think maybe it's a spectrum or a Venn diagram of overlapping symptoms, but some things might be easier to study in one population versus another for various reasons, and you can control for some things in other populations that you can't. So I think this interpopulation discussion is important.
Absolutely.
I think there's a lot to learn. But I appreciate Tay again for inviting me. I think it's coming up with a common language and just like learning how you guys talk about this type of topic is I think going to be really valuable for my career. So I intend on coming back, and I much appreciate it. Thank you.
Absolutely. And thank you for your talk and everybody for amazing discussion. Now, just quick, there's going to be some big announcement for a lot of changes in the meeting formats and other things. So please pay attention to the email. We'll renew the link and make some other announcements. So again, thank you so much for a great discussion. Have a great rest of the week.
Bye.